I am so open to students emailing me. I mean, I'm an educator and I love to teach. You can ask any one of my graduates who graduated from the EMT or the paramedic program, and this is it. This is basically my philosophy. It all makes sense. Even my students today, EMTs truly have to make critical clinical decisions, and they have to make differential diagnoses, because if you suspect you have a patient who's having a stroke, they shouldn't get oxygen. It's dangerous. It's not that they just shouldn't get it. It actually may worsen their outcome. And it's all based on evidence too. This is not, and Daryl and I were talking, this is not Joe Mistovich's ideas on pre-hospital care. This is based on science. So a lot of this is based all on the changes in science and the evidence and evidence-based medicine and so forth. As the EMT education evolves, so does this textbook. And this 11th edition is the greatest evolution there is today in EMT education and EMT care. So it all makes sense. So my whole point now is, and I say this even lecturing to EMTs across the country, that in order for EMTs to make differential diagnoses and right decisions, treat patients, they have to have a good foundation of knowledge. And their foundation of knowledge has to be based on some anatomy, some physiology, and some pathophysiology. And it doesn't have to be huge. I mean, it could be a reasonable amount. What you will find in that textbook gives them enough of the foundation for them to begin to understand. And so, man, you got to stop asking your students to memorize stuff, because 2 weeks later, they have no clue. They should be able to understand. And so that's what this book intends to do, is get the student away from memorizing, but understanding, and so they could figure it out. And so what I tried to do is shift their thinking. So it's a whole different change in their thinking process. It's like, even the student, I'm teaching pathophysics this semester, my paramedic students, I told them, I can't cover everything. Man, I'm going to cover the tip of the iceberg. But you know what I'm going to do is I'm going to change your way of thinking so you could figure it out. One thing that I try to do in the textbook is challenge students too. Challenge them. So now, a new feature that I did add, clinical chapters for the case studies at the end of the book, the follow-up case study. So my whole thing is getting these students to understand why things are occurring. So in the follow-up case study, we have a patient presentation, and it might say, and the patient has pale, cool, clammy skin. So what you'll find in parentheses is the pathophysiologic reason for why their skin is pale, cool, and clammy. I present them with the pathology, then I present them with the clinical link, so they could go forward, and then they go back. And that's kind of the attempt in that case study follow-up. Here's your clinical sign and symptom. You should already know why you're seeing it, but I'm going to tell you anyways. Because this is the way you have to think. So in the case study follow-up, this is a brand new feature. So in the case study follow-up, okay, and this is the diabetic patient, you can see what I tried to do is what I did was try to explain now, kind of like what I did is why they're seeing these things. So let's pick, so you go down to the screen on the bottom there, what says tachycardia is from the epinephrine's beta-1 stimulation. Well, weak grip, hypoglycemic patient, all this blood volume and good perfusion, peripheral pulse will be strong in all extremities. The pale, cool, clammy skin is due to the epinephrine release. So this is kind of like, here's another one. You need to know 2 things about the hypoglycemic patient. That's it. You can figure all this out. But one thing I do, impress upon them in the book too, though, is normal is only normal for that patient. That's why it used to drive me crazy, because I'm like, I used to have average heart rates, which is different than the normal range of heart rates, which is different than the abnormalities for heart rates. But they couldn't get it. I kept saying, I would always say, tell them to look at the title, and it tells them exactly what, but people, they just want it because they think that the registry is going to ask them what their range is for a 3-month-old. The registry is never going to ask them that. The registry is going to want to know whether they have an idea whether that heart rate is causing or is related to some pathology. Variations in SpO2 goals for medical trauma and other special considerations. This was another huge thing that people would say, well, it's wrong. It's not wrong. Again, this is not my opinion. This is based on the experts. So here again, if you have a medical condition, it's telling you the SpO2 should be maintained at 94% or greater. Okay, that's based on American Heart and National Association EMS physicians. If it's a trauma, this is where I get beat up. American College of Surgeons is saying multi-system trauma, hemorrhage, and so forth. You need to maintain an SpO2 of greater than 95%, because it's a lot easier for the student just to go 94. That's simple to just say 94 and greater. It's a lot more difficult to say, man, this is a trauma patient. I got to bump that O2 up. I better put them on a non-rebreather instead of a nasal cannula because they're trauma. So this is huge, this section right here. This is huge. This is the first book that actually comes out based on all the new research, let me say it's new, all the research that basically says spinal mobilization, one, can never be achieved. So you should never say that you're immobilizing a patient because it can't happen. You can never immobilize the spine. It's physically impossible to do. So in all the research that's out there, basically there's this big push. Now, here's the thing, across the country, a lot of systems have gone to spine motion restriction. A lot of systems have gotten away from the use of backboards and so forth, because all the literature is saying is that the old spinal mobilization is dangerous. It actually causes more morbidity for patients than if you didn't immobilize them at all. Opiate overdose is another big one. Opiate overdose, I have an entire section dedicated to opiate overdose, talking about heroin overdose specifically and so forth. And we added an entire section on Narcan, naloxone, administration and naloxone. I can tell you this, that book has all the latest, newest information. And it's not me. It's based on the science. It's based on the literature. I just don't want you to memorize signs and symptoms. I want you to understand. And that's the whole intention.